for your invite, and welcome to the session on BMJ and quality improvement. I am going to talk to these subjects. I'm going to give a brief introduction to BMJ. I'm going to talk a little bit about BMJ online resources, also about our conferences, relevant journals, and other resources that are relevant to this subject. And so, to start with a brief introduction to the BMJ. The BMJ is a global healthcare knowledge provider with a vision of helping to create a healthier world. We share knowledge and expertise to improve healthcare outcomes. The content is obviously relevant to doctors, but also to nurses and midwives and other healthcare professionals. Here is our home at BMA House in central London. And we're all working from home at the moment, as you would expect, because of the pandemic, but we hope that in times to come, the pandemic will come to an end, and hopefully you'll be able to join us as our guests at BMA House in London in the future. Very important to BMJ is our values. I won't read them all out, but the values are things like evidence-based medicine, having patient-centered content, having content that's independent and transparent. And of course, these are more than just words on a page. These are really important to BMJ. And of course, it's impossible to do quality improvement without these values. BMJ, of course, stands for British Medical Journal, but we joke internally and externally that we're not British, we're international. We're not just about medical, we're about healthcare and about doctors, nurses, midwives, and allied healthcare professionals. And we're more than just a journal as well. We do 70 journals. We do medical education and decision support resources. We also do meetings where we convene global health experts, many of which are experts in quality improvement. And BMJ has been around a long time. It started in 1840, the first edition. It was only 16 pages long, but you can see here from this timeline that we've published many landmark papers over that time. An early one relevant to patient safety was by Joseph Lister on antisepsis in surgery over 100 years ago. Also probably one of the very early randomized controlled trials, one of the early cohort studies on smoking and lung cancer in the BMJ. So we have a long history. And today, our history has brought us to a place where we have over 6 offices around the world, including in Delhi. We're very proud that our first hub was in India. Over 5.5 million users visit our websites each month, and we publish content in 14 languages. We have users in over 150 countries and operate in over 3,000 institutions. So we're operating on a global scale, but really important to us is India. And so what resources do we have that drive quality improvement? I'm going to talk through a few resources. BMJ Best Practice is one of the most important ones. BMJ Best Practice is a clinical decision support tool structured around the patient consultation with advice on symptom assessment, test ordering, and treatment approaches. It offers clinical decision support that works at the point of care. It's evidence-based, continually updated, and practical. If you have a clinical question and you need an answer, you can look it up on BMJ Best Practice. But you won't just get any answer. You'll get an answer that will address your needs. And the needs of users are very clear online. They want an answer quickly. And how quickly they want an answer? They want an answer within seconds. They want practical and actionable information that will work at the point of care. And they want to be able to access it wherever and whenever they are, on a mobile, on an app, on a laptop, whatever. It also needs to be continually updated and evidence-based. And that's what we try and build our content for healthcare professionals along these lines. In the quality improvement, we ask ourselves what matters to you for patients, but we also should ask what matters to healthcare professionals when we're getting them to use our resources. And that's what the next generation of healthcare professionals in particular want and need. So BMJ best practice, it covers primary and secondary care comprehensively. It's evidence-based and it's continually updated. It contains case histories, which really help to engage users. Also, treatment algorithms, which enable personalization of treatment, unique differential diagnosis tables, and also alerts, but we can't give alerts too often, just the right number of alerts with the right frequency. And a range of other features like medical calculators, so you can calculate everything from your patient's body mass index through to procedural videos, so we can teach how to do common medical procedures carefully. A usage tracker, so you can track and record your CME, continuing medical education, continuing professional development on the site as well. And also a local guidance tool so that users can see what guidance is relevant locally. We also have patient information leaflets, which are short, written in layperson's language, and they parallel the professional content aimed at a reaching age of 11. Of course, we can't have quality improvement or the implementation of evidence-based guidelines without proper engagement of patients. Patients need to be partners in this also. And what's the relevance of clinical decision support to quality improvement? Well, we've published papers in this regard, and we've demonstrated that individuals use clinical decision support to drive quality improvement, that clinical decision support can be integrated into programs of quality improvement in infectious diseases and other specialties, but also, and this is particularly important, that online clinical decision support can be delivered at a lower cost than traditional forms of clinical decision support. And I'm often asked, is clinical decision support online better than traditional forms of support? And in some ways, that's the wrong question. It's not that it's better or worse. It achieves broadly similar outcomes. But the main difference is that it's cost and convenience. And so we need to leverage those things. And more about that in a second. BMJ Learning is our online interactive multimedia medical education. It contains continually updated, evidence-based, interactive, case-based learning modules. You learn some content and test your learning at the end by an assessment. It's time efficient and so short. And here's some of the features I've been talking about. Case-based content, which really helps to engage healthcare professionals. Image-rich, clinical images, short chunks, so users can do short bites at a time and also receive feedback on their learning as they work their way through. It's about the practical application of knowledge, and users like to test and train their skills as they work their way through the content, sometimes through watching multimedia videos and ultimately getting a certificate that's personalized to them. How is it relevant to quality improvement? Well, once again, we've demonstrated and published evidence of the effectiveness of our approach, that individuals use e-learning resources to implement guidelines and to drive quality improvement within their institution. But also, really, really importantly, is that the e-learning resources can be a cost-effective and environmentally friendly means of delivering healthcare professional education. But to enable that to happen, we need to leverage it. We need to scale it up, ensure large numbers of users are using it. We need to share it between institutions, share it between professions as well, so that doctors, nurses, allied healthcare professionals use the content and use the content to put their learning into practice and achieve better learning outcomes. And we have a series of e-learning modules on quality improvement planned. These will be published next month. And here's the curriculum of resources. It covers foundations of change. That users will learn how to become agents of change, because we know we need agents of change. I should say at the start, all the content is outcomes based. So it's not about what you might learn, but what you might be able to do at the end of it for the learners. And that's a real key thing in education, all education, but particularly so in quality improvement. Also, we will have content coming soon on clinical leadership. Can you have quality improvement without good clinical leadership? No, of course not. And it will particularly emphasize interprofessional leadership, with where we have good leadership of all members of the team. And of course, nurses and midwives are key parts of the team and can have leadership roles as well. It'll cover a systems-based approach. Doctors too often think in straight lines and think that change is linear, but of course it's not. And we need to influence systems and develop systems if we're to deliver quality improvement. And I should say, all these topics are based on the needs of learners. The content will also cover practical project management, which of course speaks to itself. It's self-explanatory. I won't read out all the learning outcomes. We also have content coming on stakeholder relationships. And of course, the stakeholders include patients and their relatives and carers, who are perhaps the most important stakeholders, but also nurses, allied healthcare professionals, different members of the team, key to delivering quality improvement. We also have content on intervention design, which is self-explanatory and yet not simple or straightforward. We all have examples of interventions which are not well designed and therefore not used. And what we found, particularly with the clinical decision support and e-learning resources, is that they have to fit with the clinical workflow of the doctors and nurses and other healthcare professionals. If they don't, they simply won't be used, but they have to be designed so that they'll fit with the clinical workflow of the healthcare professionals. We'll also have content on models for improvement, such as the PDSA cycle. And in the UK, 10 years ago, when you asked junior doctors whether they understood PDSA, even what it meant, very many of them didn't. But over that time period, the majority now do. So it takes that time period, it takes 5 or 10 years for these ways of looking at things and developing these models and educating about these models. It takes a number of years, but it can happen, and it will happen in India also, not just with junior doctors, but with nurses also. The content will cover human factors and will borrow on thinking from simulation, because of course we know that human factors are really key to developing quality improvement, and a team-based approach is key. Patient safety will be a core part of it as well, so that we will be teaching doctors how they can design out error. And lastly, measurement for improvement, which of course is vital, but often not done properly. And that's a key outcome to be achieved. And I should say, all these resources which are coming soon have been developed based on user needs. So these are things that users say that they want and need, not just in the UK, but internationally as well. So that's the e-learning modules on quality improvement coming soon. So that's our online resources, but with other resources also, such as events in quality improvement. And here's all our events. Not all of them are completely relevant, but I'll talk to the ones that are: the International Forum on Quality and Safety in Healthcare, and also leaders in healthcare as well, and I'll concentrate on those. So here's the International Forum on Quality and Safety in Healthcare, which is a forum that's been going for 25 years now, happens in Europe and also in the Far East, and we have plans to bring it to India next year as well. It's jointly produced by the BMJ and also the Institute for Healthcare Improvement, the IHI, in the USA. We have as many as 5,000 delegates a year to come along to our two conferences. It contains a massive amount of resources and practical workshops, and we can, if need be, create tailored learning tracks for cohorts of users who want to, say, improve their leadership skills or meet with particular key experts, or indeed have the opportunity to submit quality improvement posters, and more about that in a second. And we say that we have the royalty of the quality improvement world coming along to our conference. People like Don Berwick and Fiona Godley, and we do. But occasionally also we have real royalty who come along as well. So a couple of years ago, when the Quality Improvement Forum in London, we had Princess Anne who came along, who gave a really good talk to us. So that's what we aim to achieve. There's posters in the Quality Forum, and also an opportunity to network and talk to your peers and learn from your peers as well. That's one conference. Another relevant conference is Leaders in Healthcare, which attracts about 1,000 attendees every year to a 3-day event. I should say all these conferences are going virtual this year because of the pandemic, but we hope them to be back to normal next year in 2021 when the pandemic has come to an end. And of course, there's a massive overlap between clinical leadership and quality improvement. One doesn't really work without the other. And so here are the typical program themes to the Leaders in Healthcare event. We also have journals, of course. We're the BMJ, we would have journals. We've got over 70 journals. I'm going to concentrate on 2 that are really relevant to quality improvement. First of all, BMJ Open Quality, which has been going for about nearly 10 years now. It's open access, peer-reviewed journal dedicated to quality improvement and patient safety within healthcare. It started off as BMJ Quality Improvement Reports, and it still continues to publish quality improvement reports, but it now also publishes original research, systematic reviews, and short reports. It's all peer-reviewed, it's open access, and it also enables fast track of publications as well. And it was introduced because we felt that many people working in quality improvement didn't have a place to publish their work, and therefore weren't getting sufficient credit for their work and weren't able to share their work. And people then weren't able to learn from them either, or couldn't reproduce their work. And the purpose of the journal is to overcome those problems. But because people doing quality improvement should be able to get publications and should therefore get credit from their work. It's open access, and therefore there are APCs. We very much encourage patient and public involvement in research, and also data sharing. And there's a range of resources on how to get published in quality improvement reports. And some of you or your colleagues or your juniors may be interested in getting published in quality improvement reports or others of our journals. So let me take you a minute or two just to give you some tips on getting published. And the most important tip in the case of BMJ Open Quality is to follow SQUARE guidelines if you're submitting a quality improvement report. SQUARE guidelines are from the Equator Network, and they're very straight. They're all freely available on the Equator Network, and they give very straightforward and simple guidance on how to write up your quality improvement report. And if you follow SQUARE guidelines, there's every chance that you'll get published. Every chance that you'll get published. And if you don't, then your chances will be reduced. And here are the square guidelines or sections of them. Of course, title and abstract are at the start. And I'm going to pause for a second here and emphasize the importance of thinking a little bit about your title and your abstract and your cover letter, because you want a title that will engage the editor and peer reviewers. So spend some time looking at the best content on BMJ Open Quality and look at the type of titles that they publish and see if you can come up with a title that's similar to that. Obviously, follow the guidelines for the abstract and make sure you get your abstract as good as you possibly can. Submit a cover letter with your paper as well, with your report. And in the cover letter, say what you did, but also say why it's important, why it's topical, why it's international. And if you say all these things, the editor will really look very favorably on your submission. And it's important to spend time on these things because often papers are screened by the editors and peer reviewers on the title and the cover letter and the abstract. So you might do a fantastic job in the methodology, but if the editor doesn't really like the title and the abstract, they might not ever get as far as the methodology. So it's worth spending time on these things. And yet doctors, they don't, they leave it till the last minute, and often they're exhausted having written up their 5,000 words by the time it's time to submit and put it in the right format. So it's worth pausing for a day or two and getting these things as good as you possibly can. Of course, in the introduction section, you'll state why you did the research. And a common error in that regard is people can sometimes write too much. I keep it nice and simple and brief, and then move on to the methodology, explaining exactly what you did. And that's really core to the paper, and you've got to describe it in as much detail as possible so others will be able to reproduce your work and understand your work. Then it's simple matter of stating what your findings were, what the results were, what the outcomes of the quality improvement project were, and lastly, what the conclusions might be. And here, a common error is people can exaggerate and write too much and say there's a groundbreaking paper when sometimes it isn't. So here, be modest and explain the relevance of your findings locally or regionally or nationally or whatever. Point out the limitations of your own paper before other people do as well. The editors and peer reviewers will really think you're much more realistic. And then, and one final journal I'm going to mention is BMJ Quality and Safety, which publishes also a range of research work and reviews and scientific thought leadership in quality improvement. It's got a higher impact factor than BMJ Open Quality, also more difficult to get published in as a result. But that's if you think your paper is of higher quality, then it's certainly worth thinking about this journal as well. So one last resource I'm going to talk about, and then I'm going to hopefully answer some of your questions. Quality improvement in complex circumstances. And I mentioned this deliberately because you might have a quality improvement project in how to improve care in patients with cardiac failure. And you might think, well, I'm just going to concentrate on cardiac failure. But I hope to show you over the next few slides that that in itself may not be enough, because heart failure, like many other diseases, doesn't exist on its own. It exists with comorbidities. And I'm going to talk to you a little bit about the comorbidities tool, which is an add-on to BMJ best practice, which we started on. Most patients in the acute setting have more than one medical condition, and yet clinical resources all focus on single conditions. And when comorbidities aren't taken into account, patients get suboptimal care, leading to worse clinical outcomes and longer lengths of stay in the hospital setting. 1 in 4 adults suffers from more than one condition, and this is across the world. It's in the UK, it's in Ireland, it's in Europe, it's in the Middle East, of course, it's in Asia, India, and China. I've done research on this for the team, and it's in all countries around the world. Remarkably, in the UK, 1 in 3 adults admitted to hospital as an emergency have 5 or more conditions. And patients with multimorbidity have poor functional status, quality of life and health outcomes, are higher users of care, and have higher mortality. And this all poses a significant problem for healthcare systems. And yet resources for healthcare professionals only focus on single conditions. Here's Chris Whitty, who's the Chief Medical Officer in England, training from medical school onwards. Clinical teams and clinical guidelines all tend to be focused along single disease or single organ lines. And so in light of that, we launched BMJ Best Practice Comorbidities, which enables doctors and other healthcare professionals to add a comorbidity to an existing management plan and get a tailored plan instantly. And it supports healthcare professionals when treating the whole patient and thus delivering holistic care. And what happens then is that you can add 1 or more of these chronic comorbidities to your patient's acute condition. And the number of potential combinations grows exponentially, so that when we have 50 topics, which will be by the end of this year, there's over 25,000 possible combinations. And so comorbidities are really common, and patients with single conditions are increasingly rare. So I spoke to a cardiologist a couple of months ago, and he told me he couldn't remember the last time he saw somebody with a single condition. All of his patients had comorbidities. And this will be the only clinical decision support tool designed to address comorbidities. And of course, in keeping with quality improvement, we plan to evaluate it. We're doing an evaluation live at the moment in a hospital in the north of England, and we're hoping to answer these questions. But I guess my take-home point again is that sometimes quality improvement it can be not a straightforward business. It can be difficult to try and do quality improvement in single conditions when your patients have multiple conditions, and therefore you need resources that will take into account the complexity of the clinical situation that you face. So in conclusion, I hope that I've shown you that there's no single one best way to do or support quality improvement. There's a multiple means of doing this. And there are many problems and many different types of problems that need to improve. And also many different types of resources that will help doctors and other healthcare professionals to improve. And so we recommend using a multiplicity of approaches, and sometimes using a number of different approaches. And people who want to learn about quality improvement, doctors and other healthcare professionals who want to learn about quality improvement, need to, sometimes they will like and want to and need to go to meetings. Sometimes they'll want to go online, and sometimes they'll want to read journals or get published in journals. And so you need a blended approach, an interprofessional team-based approach that will engage doctors, nurses, allied healthcare professionals, and midwives if we're going to succeed. But we would emphasize, and we would say this coming from the BMJ, to publish and share and learn from peer reviewers and from your colleagues who comment on your paper, and share your ideas with others. I hope I've shown you the kind of the complexity of the challenge that needs to be overcome if we're to achieve high quality healthcare. And it's a challenge that needs to be overcome in all countries in the world. And these are not simple problems to solve. And we've discovered at BMJ that we cannot solve them on our own. We need partners. And we already have partners in many parts of the world, in the US, China, Brazil, around the world. But we hope that India will continue to join us as another world-class partner. Thank you very much for listening. I'm very happy to take any questions that you might have.
Thank you so much, Dr. Walsh, for those inspiring words. It's indeed provided us great insight into the process which is followed at the prestigious British medical journals. It was heartening to know about the spectrum of activities which are directed towards quality improvement by the BMJ group, and also the journals which are specifically focusing on showcasing the work in low and middle income economies. Now, before I open up for questions, I would request we have BMJ South Asia Managing Director Prashant Mishra with us. So I'll request Prashant to give his perspective, and then we'll come to Vivek Singh from UNICEF, and then I'll be taking the questions and finally closing with the perspective and question answer sessions. So Prashant.
Okay, so thank you, Dr. Vikram, for giving me an opportunity to talk. I'll keep it very brief. I think Kieran has, as always, Kieran has done a great job. So I think what I would really want to say right now, we are now at a stage where, in principle, BMJ and Nationwide Open Quality Care Network, we've decided to join hands. And this is on multiple fronts, but one of the most important areas where we've decided to partner is by helping your doctors, your teams who are doing quality improvement work at the real community settings to get their work published within BMJ Open Quality. So the plan is to introduce an annual themed issue of BMJ Open Quality for the South Asian work that's happening. I'm very hopeful that in the next couple of days, we should be able to sign the agreement, which is already in the discussion. So we've made significant progress, advancement. So hopefully that should get signed, which would then mean that there would be an announcement for call for papers. And I think I would encourage each one of you to do real good work. Hopefully you're already doing the job. But what Kieran said, I think that's very important. So every journal demands a certain way in which work needs to be submitted. So do give it a due look, and that would definitely help the people on the ground. So that's one thing. The other, obviously, he did focus upon a couple of other tools, products, especially BMJ best practice, which we believe it's a very powerful, clinical decision support tool. And with the comorbidities thing that has been recently added, we are still building. As he said, we hope that we'll have around 50 topics by the end of this year. But then if we apply the permutations and combinations, it actually becomes too wide, right? So I think that's something which could be a very strong tool in the hands of the people who are really doing practical work on quality improvement on the ground. So that's the second thing. Third, and probably the last thing from my end, he did talk about the course on quality improvement that we are expecting to launch in UK and globally as well. It was expected in October, but I believe it would be early November. So that's another area which could be a very powerful tool for early career, researchers, practitioners in the area of QI and patient safety to get enrolled in. I'm sure the learnings would really give them a new dimension. They'll be feeling more confident in going about doing the real job of quality improvement there. So with these few words, I'll pass it on to you, Dr. Vikram. Thank you so much.
Thank you so much, Prashant. And here I would like to thank BMJ India and especially BMJ International for allowing NQOCN to bring out a special South Asia issue of BMJ Open Quality on an annual basis. And this is my request to all the participating teams. I have all the national mentors here, Prashant and Dr. Walsh, who are here, and also Dr. Vivek Singh, who have done phenomenal work. And when I was talking to the editor-in-chief the other day, Dr. Helen Chris, I was just mentioning that, and Dr. Walsh has also echoed that, that's a lot of work which is done in the low and middle income economies, right across the SNCU network, right across the maternity wings, right across the labor rooms. And right now, the government of India, the main focus, as you all know, in our quest to achieve UHC, our country has launched the Lakshya program, that is the Labor Room Quality Improvement Initiative. And I'm proud to state here that NQOCN is a national technical lead for the National Mentoring Group for Quality Improvement for the Lakshya program for Government of India. And we've been steering before the pandemic through on-site visits, a lot of quality improvement work, and very actively partnering with UNICEF for nearly 3 years plus into the field level facilities to pick up, handhold the teams into quality improvement. And Dr. Vivek Singh and his team at UNICEF India country office have been greatly supporting this endeavor, and they have also been looking forward to active partnership with NQOCN right through, and also with a component of strengthening the nurse mentors for quality improvement. So I would now request Dr. Vivek Singh to share his vision and also let us know how he feels UNICEF can collaborate in this effort and or synergize in this activity. Dr. Vivek Singh, sir.
And John, we have you. Thank you, Professor Datta. I would, first of all, let me officially put from the UNICEF team side, congratulations to the team for this wonderful initiative. And in spite of our COVID pandemic, the importance of stressing on quality at this time. So I think some accolades also for keeping this high on the agenda, the quality of care, why it is important. And now coming back to why we specifically wanted to collaborate with this BMJ, and I see Prashant on line that we had some discussion with a group, and my apologies if I'm forgetting, at the Prince Mahidol Awards conference where I met some colleagues from BMJ, and we were talking about the quality forum that was supposed to come to India. So from UNICEF's perspective, which as an agency has the mandate, and I work for the health section to support the government both at the center and in the states on protecting and promoting children's right to survive and thrive, and mainly through health and nutrition interventions, which are cross-sectoral, of course, on determinants. So the reason we thought that this is an important piece of partnership, and that is why we thought we should partner is, as we have been mentioning earlier, that there are a lot of case studies emerging from all these quality initiatives that you mentioned. And we have seen that over the last decade, how implementation of programs has actually evolved into implementation science, so to say, as we call it. And I think it is now, and I mean, it's not just in my personal capacity that I'm also an adjunct faculty at the Rollins School of Public Health at Emory University. But I always feel that now more and more, and especially UNICEF team in India, we are realizing the importance of Connect for knowledge translation for practice. And I think this is where people like your team who are working at this interface of academia, applied research, and also who know the program so well. So we need to create leadership like this from the grassroots, where we are able to get case studies, case reports from the field in such publications, which can also be then used in pedagogies, case study-based teachings of health workforce across the country. So I know that these things will take long time, but I think these are very important steps. And I think this is a congregation of the right kind of stakeholders who will have to take these steps. And I'm very happy that this is happening, and wish you all the best. And thank you to Dr. Walsh for the presentation, please.
Thank you so much, Vivek, for those words. Dr. Walsh, any comments on Vivek's observations?
No, I would broadly agree with many of his comments. I think lots of different countries in the world are at different stages of developing their quality improvement methodologies and developing their experience in it. And we're all improving in the UK and in the US as well. A couple of years ago, I saw Don Berwick of IHI give a keynote at the Quality Forum in London. And Don Berwick has been working in quality improvement for 30 or 40 years now. And Don Berwick said, we're all at the beginning of quality improvement in the US, in the UK, around the world. We've got a massive amount to go to disseminate knowledge, to develop our skills, to change our behaviors, and to systematize and embed quality improvement. But that's what we need to do.
Thank you so much, Dr. Walsh. So I will now be quickly taking the questions from the participants and esteemed colleagues. So the first question is from Dr. Anupa Vik. Dr. Anupa wants to ask Dr. Walsh, is the clinical decision tool tailor-made for the Indian context also? If we start using it, for example, does it also use the Indian practice guidelines, or is there some section which makes it more country-specific contextual, or is it referring to international guidelines? Or like when we follow it in India in the public health sector settings, or NQOCN tries to roll it across public health sector settings, will there be some contextual reference to Indian guidelines also? It would be all international.
Okay, thank you. That's an excellent question. And it's maybe the most common question that I get asked when giving talks on Zoom or also when traveling around the world. And so BMJ best practice is based on the best available international evidence, recognized guidelines like from the World Health Organization or other similar bodies, based on Cochrane clinical answers, which in turn are based on Cochrane reviews, and similarly on large, respected, best of breed regional guidelines. So that's number one. But number two is that we've recently added new functionality to BMJ best practice called the local guidance tool, which enables countries to upload their own local guidance or protocols relevant to the disease in question, so that the doctor or other healthcare professionals can see both the international best evidence and also the local guidance, which is what doctors and other healthcare professionals tell us that they want. So that's available now.
So thank you so much, Dr. Walsh. That brings me to the second questions from Dr. Aarti Kinekar. She is head of the department at Pune. Dr. Kinekar wants to ask, is there a section on COVID with comorbidity approach to management? And are there any QI projects that are directed toward COVID patient care in BMJ right now? There are any reports which have been published in Open Quality or Quality and Safety?
Okay, thank you. Another excellent question. So COVID is covered comprehensively on BMJ best practice. It's been updated every day for the past 6 months. It's got about 1,000 references in it already. Remarkable in such a new disease. You can add comorbidities to the treatment algorithm of the COVID topic as of last month, which of course is really important and really good news, because we all know it's the patients who have COVID who also have comorbidities who run into real trouble. Patients with diabetes, with heart failure, with chronic kidney disease, or patients who have COVID and diabetes and heart failure and chronic kidney disease. And so the treatment algorithm does cover the acute COVID condition, but also these common comorbidities. In fact, over 10 comorbidities, many of which are the ones that you will read in the scientific literature about COVID-19 that states that having these comorbidities will result in higher morbidity and mortality. And it does so in a very simple and straightforward way. So for example, if you have COVID and diabetes, then you need to be careful with steroids. You need to ensure that you monitor blood glucose very carefully. If your patient is going to take Remicade, then blood glucose needs to be monitored very carefully. Pressure points need to be monitored. If experimental drugs are given, then the diabetes and interaction with existing diabetic medication needs to be monitored really, really closely. Very straightforward, simple things, and yet things that are missed and neglected all too often with, unfortunately, poor quality care. The second part of the question was related to whether COVID-19 is covered, whether we have quality improvement reports on COVID-19. And I don't know the answer to that question, but I can send you I can look and I'll send you an email as soon as possible. Like COVID-19 is covered extensively within BMJ and within the BMJ journals. And we've got a range of editorials, guidelines, commentaries, original research, systematic reviews on COVID-19. But specifically on COVID and quality improvement reports, I'll come back to you by email.
Thank you so much, Dr. Walsh. There's another question from Dr. Valvi, one of our national mentors from Pune again. Dr. Valvi says, excellent talk, Dr. Walsh. It was interesting to know there's a separate section related to system change in one of the e-learning modules. Can you please highlight further regarding the system change section? I know it's coming up next month. Prashant has told me in greater detail about it, but of course, your take on that.
Yes, sure. Like all I would say, and I want to keep my answers reasonably short, but because I know you've got to get on with your agenda, is that system change was a learning need amongst learners when developing the course, and that doctors and other healthcare professionals are not trained in system change, and they need to. And the idea that you can come along with a randomized controlled trial and have a single intervention and that it will improve things, it doesn't really take into account the realities of modern medicine and modern healthcare, which is complex, which is multi-sectoral, which is interprofessional. And so you might make one small change to one part of a system, and it will have multiple knock-on effects on other parts of the system. And therefore, it's something that doctors and other healthcare professionals need to do better on and need to improve. I would say that it's also, it's a topic, it's a hot topic. It's something that's become more important over the past 3 or 4 years. When I first went to the Quality Forum 10, 12 years ago, it wasn't spoken about much, but its importance in changing things and embedding change within the new system is increasingly important. So, and we want quality improvement to be sustainable. We want improvements to be embedded and not to go back to the old ways of doing things. And without system change, that won't happen.
So Dr. Walsh, that raises a question in my mind also. We recently published a hub and spoke model for quality improvement in BMJ Open Quality, where we had a lot of experience that directing all the changes towards the point of care team leads to change definitely, but it is often not sustained unless and until you direct, towards the system, that is the macro and the meso levels of the health system. So my question here is very simple and straightforward, that these tools would be probably directed towards the end users, that is most probably the point of care teams. So has this, the e-learning platform also got certain, resources which are directed towards the policy planners or the administrators who are at the higher levels of hierarchy of the health system, which are specific to them, like somebody sitting in the ministries of health, or maybe maternal health division or child health lead. So any takes on that? Any resources for those level?
Okay, thank you. So I would say that the e-learning resources that I spoke about are practical resources aimed at people on the ground who are undertaking quality improvement projects and trying to make a difference. For the second target group that you're talking about just there now, most laterally, they might find it helpful but they probably need different types of content as well. And I would say encourage them to look at the editorials and commentaries and reviews in BMJ Open Quality, but also in the sister journal, BMJ Quality and Safety, and they'll be more likely to get an answer to their higher order questions in those journals, I think. Also sometimes in the BMJ.
Thank you so much, Dr. Walsh. The next question is from Dr. Aarti. She says, are there any writing workshops conducted by BMJ in relation to QI projects, writing and publications for faculty and medical students in India?
So we certainly do workshops, writing workshops, or how to get published workshops across the board on a range of different subjects. And we've done more of those since the pandemic, since the lockdown. And one of the advantages of the lockdown, it is in some ways it brings us closer together with our colleagues internationally, including those in India, both within the BMJ and outside of the BMJ. So I think that myself and Prashant would be really happy to talk to institutions about how we might be able to help with writing workshops. I did a writing workshop last week online to another group of researchers who are interested in COVID. So I'd be really happy to do that. And we'd be keen on a workshop-based approach, because a bit like this session, it's great to be able to talk, but it's fascinating to get people's questions and to try and answer their questions and to have a dialogue. So a workshop approach, I think, works best.
So, Dr. Walsh, there are multiple questions regarding the acceptance rate of BMJ Open Quality, the articles processing charges. I think Prashant and me would be happy to answer them. I think there is a special arrangement for the special South Asia issue, which is going to be, once the contract is finalized in the next couple of days, NQOCN office is going to be getting back to you people, and we have Dr. Vivek Singh from UNICEF, who is kindly supporting this entire endeavor. So we have all the support, so it will be tweaked for the Indian context, and we will be getting back to you with greater details. There's a question from Amol Joshi from Aurangabad. Amol says, how likely is the app-based tool for clinical decision making significantly able to reduce human errors? Over-dependence on system-based approach would make it into algorithmic approach rather than customized approach, when we know that no two patients are like. Please opine.
Okay, thank you. So just to come back to the first bit, we said acceptance rates for BMJ Open Quality. I think acceptance rates are around 60%. So not bad. You have a reasonable chance. If you want to increase your acceptance rates, if you want to get higher than 60% chance of getting published, there's a lot of resources on the author page of BMJ Open Quality. In fact, there's a guideline. I looked at it a couple of hours ago on how to write up your quality improvement report. And I can't emphasize enough to read through that in as much detail as possible and to try and follow the guidance. It's amazing the number of reports sometimes that we get into this journal or other journals where the authors haven't followed the guidance and sometimes haven't read the guidance, and their acceptance rates will be an awful lot less. So I would say Squire guidance on the Equator Network will increase your following that, and also following the guidance on the website. The question about errors and BMJ best practice and algorithms on it, and all patients being different. Absolutely, all patients are different, and we have treatment algorithms now on BMJ best practice, so that you find out not just how to manage somebody with an ST elevation myocardial infarction, but somebody with an ST elevation myocardial infarction who is come to hospital within 4 hours, who's come to hospital where there is an angioplasty lab and who is fit to have angioplasty, but also who has chronic kidney disease and type 2 diabetes. So the treatment algorithms on BMJ best practice are becoming much more sophisticated, and they're a step towards personalized care. So it's not just how to treat somebody with an MI anymore, it's how to treat somebody in this particular circumstances with these particular comorbidities and with this type of MI. And that is the future of medicine in many ways. We can only look at the genomics revolution and realize that in 5-10 years' time, people won't be diagnosed with diseases like asthma anymore. They'll be diagnosed with a particular subtype of asthma based on their genomic profile. And so the need for clinical decision support will become much, much greater in the future, because people will need this type of personalized care, and doctors and other healthcare professionals will need personalized support to enable them to deliver care. So it's an excellent question that looks to the future.
So Dr. Walsh, before we conclude, just two very quick questions, if you permit. We are already 9 minutes beyond the schedule. But
I'm happy to stay as long as you want. It's my fault we've run late.
Thank you so much. We are indeed humbled, sir, by that offer. So we have a question from our nurse mentors, sir. And that brings me to a very important chunk, sir. NQOCN always believes that the nurses are the backbone of any quality improvement process in the country. And just to mention here from this platform that NQOCN has got the largest nurse mentor pool for quality improvement in country. In fact, I would say rather than the greatest network in the whole South Asia for the nurses, I think exists for NQOCN. And this has been documented by WHO Geneva also, and also has been published in the Indian Pediatrics, which is a key landmark journal of pediatrics in India regarding NQOCN. So here we have a question from Stella Rangare. Stella is a national mentor and a great QI enthusiast. She has been working on quality improvement for nearly 3-4 years now, and she's been mentoring district and sub-district facilities in Madhya Pradesh with UNICEF support, and also a national mentor for Government of India. So Stella wants to know that there's a lot of work which these nurses are doing. She's right now posted in Aurangabad Medical College, and she wants to know that is there any hand-holding group which can help the nurses to focus more and understand how they can showcase their work, and they can take it forward, bring it to the level of the publication, etc. So I think Prashant can have a take on that, and then definitely I would like to request Vivek Singh also to comment on that. And then finally, I would like to have comments from Dr. Walsh, how he responds to our expectations from our nursing colleagues. Yeah.
So when I personally feel this is more targeted towards Kieran only, this particular question, but my 2 cents, and we talked about the podcast for the nurses. That's why I said Kieran is an authority to speak on the podcast. He himself does a lot of them. So that's one of the areas. The other being Dr. Vikram, as part of the hand-holding, BMJ does reach out to a lot of subject matter experts, especially clinicians, for a series of clinical events. And I'll not be surprised if we could do very much the same when it comes to nurses. A kind of a nurse leader, a thought leader in a particular space. And we'll see if we can bring someone of that caliber who could then share their experiences, their knowledge, wisdom with nurses like Stella and others. So that's something which I'm taking a note of, and we'll get back to you with more details. So I would stop. And as I said, I'm sure Kieran would be able to shed some more light when he talks about it.
Yes, thank you. Thanks, Prashant. And we would certainly encourage nurses and nurse leaders or aspiring nurse leaders of the future to learn about quality improvement, to use the resources that I've outlined. And the resources are generic. They're not aimed at doctors or any single particular profession. They're relevant to everybody. Also, if and when we do podcasts, we design them to be available and to meet the needs of all healthcare professionals. We would encourage them to use these resources, also to read existing quality improvement reports on BMJ Open Quality, to follow the guidelines on the site as well. And when they do look at the reports, they'll see that most reports are written by small teams of doctors and other healthcare professionals, small interdisciplinary teams. Often they're not written by people who are professors of medicine or deans or leaders of institutions. Often they've been written by people who are on the ground, who are doing the quality improvement work. So I think it's as much a matter of confidence and encouragement. They're more than capable of leading on quality improvement projects and writing them up to a standard that will be acceptable to BMJ Open Quality, and we would welcome such submissions and encourage them.
So, Dr. Walsh, I would thank you so much for that response. So I would, before I come to Vivek, I would just like to add here that we would specifically like to ask from you whether there is any mechanism in BMJ which can build the capacity of the Indian nursing colleagues into developing experiences from the field in way of podcasts in local contextual settings using local languages, because we can develop the podcast using our network. But if we have some, hand holding from the BMJ teams or some subject matter expert who can let our nursing colleagues, maybe a one-day workshop for our nursing colleagues across India who could probably, tell them the basics of how to develop a good podcast, how to make it more engrossing, what should be the ideal duration. I'm just throwing out ideas at you. Can BMJ assist this part of the world in developing resources? We've lot of stories, and Vivek would also echo that, lots of stories which have light, which are buried. We need to dig them and bring it forward for the world to see and hear. So that is something I wanted your specific response on.
Thank you. Yeah, so we'd be happy to help in whatever way we can. We've been doing podcasts particularly for about 15 years now. So we've done thousands of podcasts on clinical and non-clinical podcast subjects, and have a wide range of experience of the technology, of the techniques of interviewing, of storytelling, of engaging users as well. It's very much a moving target, I would say, with podcasts and other multimedia approaches. I remember 10 years ago when we did our first multimedia video, I proudly stood up and said, our resources are short. These videos are 20 minutes long. And when we talk to junior doctors and nurses and other healthcare professionals today, I ask them how long will they watch a video for? And they say 2 minutes, 90 seconds, and I might click on the little icon and watch it at double speed. So it's very much a moving target. Things are changing, and we've got to stay up with the practice and habits of learners in the UK and around the world, particularly young learners as well, if we're going to engage them. So that's just one insight that we've learned ourselves, and we're continually learning ourselves, but we'd be happy to share other similar insights with you.
Thank you so much for those insights. Yeah, Dr. Vivek, please.
Thanks, Professor Datta. I think I would just stress on two very important points. One is, this is the year which is declared to very rightfully to the nurses and midwives across the globe. And COVID pandemic has again shown to us that with more than 70%, I mean 3/4 of our workforce is nurses, midwives, and also the gender issues. What we need to do is, and through such platforms as well, which are now much beyond just peer-reviewed publications. We saw the portfolio of what BMJ does. And we see that publication houses like BMJ and others, they are now also driving global health policy. And they are making the right noises, which are leading to certain transformative changes, even in the way the world is looking at the health workforce. So what I think through these varied things, I mean, not just, and I'm being very candid, not just putting our nurses through another pressure of, not being able to do a peer-reviewed publication, rather than trying to empower them, for example, through the podcast, or as rightly mentioned by Dr. Walsh, as part of a team, if their work gets published and gets wider audience. So I think we need to engage nurses through all these range of things in building that leadership. And why I'm again stressing on the leadership issue for nurses, and thanks I took cue from that journal slide which Dr. Walsh had, that look at the nursing leadership in India, the vacuum there is, and that is across the globe in low and middle income countries. It's not that we do not have nurses of good quality. I still remember my medical interning days when I slipped the thermal cautery slightly, and it was the senior nurse who chastised when I was being reprimanded by the resident, that I know how you have learned and how much time you took. You cannot, talk to the kid like this. So that's the kind of leadership nurses have given their platform. They have that they drive agenda in clinical care settings. They can drive agenda in public health. But we need to give them platforms to build that leadership. And I think it is this podcast and other ways in which we now can engage through publication houses like BMJ, where we see value in this partnership where we had. And for India, the second point which I wanted to stress is that even the government is very keen on this. And we saw that in spite of COVID, the additional secretary and mission director herself took a session on the Nurses and Midwives Day. And then recently, government is also trying to expedite neonatology nursing fellowship program, which will have a transformative change, at least in one of the areas where UNICEF drives its flagship results for support to government, which is newborn mortality reduction. So I see a lot of opportunities for building nursing leadership capacity, so to say, through all these actions through this partnership. Thank you very much.
Thank you so much.
Add one last comment. Sorry, Professor Vikram. I'd add one last comment, is that you can go for a journal publication, but there are other forms of publication as well, like posters or e-posters. Now we're in the world of virtual conferences, which can be a stepping stone to larger publication. The first publication that I got was a poster publication, but I was able to grow from there. And starting small, it can give people confidence, and then they can grow their skills.
So Dr. Walsh, I will take a privilege of asking one last question now. We have a large collaborative of young professionals in NQOCN. It's called Be the Change Group. Now, this is a group of undergraduate medical and nursing students who are learning quality improvement and showcasing their work globally on global platforms. They've done podcasts for WHO headquarters, Geneva. They are cited on Global Quality of Care Network. Their stories up on our Communities of Practice webpage, and they've spoken on the Partners Forum. So there's a pretty famous group, Now, these are all undergraduate students from the second semester onwards, right to the intern level, and even our BSc nursing students. Now, on behalf of the students, I was interacting with few of them. I'm sure they are there in the attendees. So my question is, they were pretty excited about the student BMJ, and how they could showcase their QI work there. Because, most of their QI work is not hardcore clinical work. It is something to do with screen time reduction, increasing the physical activity. These were some of the QI projects which they did initially, monitoring their mood swings, etc. And this is what they presented in the National Partners Forum in December, where we have 50 partners all across India organized by government. And Prashant was there. And this was a group of students. They wanted to know if they want to showcase their work. in one of the student BMJ or any other journal which you feel is okay. Your take on that, Dr. Walsh?
Yeah, so we'd welcome submissions from, regardless of the background of the healthcare professional, whether they're undergraduate student, postgraduate trainee, or fully qualified healthcare professionals. If they've got something interesting to say, or if they've done an important piece of work, then we're really keen, and we'd be delighted if they wish to submit their work. If you look at the journals, the content comes from healthcare professionals from a range of background and from a range of seniority, including undergraduates. And people, just to add on to what Vivek said about starting people on their journey of publication, we have a section of BMJ called BMJ Opinion, which is for blogs, and people might want to tell their story via blogs, and we accept them from around the world. So what you're describing, I'm sure we would welcome that and be interested in things like that.
Thank you so much, Dr. Walsh, for that patient question and answer session. I think it was a very interactive session, and I'm sure my teams across India have really benefited from interacting with the BMJ leadership here, both across South Asia and the international leadership. We're also very happy to have with us the UNICEF leadership from India country office, large number of national mentors and office bearers of NQOCN. I'm very thankful to all of you for sparing your time and being here for this session, and especially my nursing fraternity and my medical and nursing students who are learning the quality improvement basics. Well, when I say learning, we are all learning. If Don Vivek is learning, we are all learning still. Definitely nobody is a master in quality improvement. Each day is unique. We look forward to working very closely with the BMJ group. And we are very excited with the launch of the South Asia BMJ Open Quality Edition. And I request all the teams who are participating today, you've heard the presentation from Dr. Walsh, follow the Square guidelines, and let's put up a good show and bring out a very good issue. And let's make it an annual event like Prashant is saying. Thank you so much.
Thank you very much for having me and Prashant, Professor Bikram. It's a real pleasure to talk to you all. I'm sure there might be some more questions. If people wish, they can email myself or Prashant or yourself, and maybe you can forward on the emails to me, because some people don't like asking questions in a public forum. That's fine. Just send it via email. We promise we will get back quickly. We always do our best to answer questions. But I'm very grateful for the questions that were asked, because it enables us to improve our resources. And there's nothing worse than speaking into the ether and getting no questions at the end. So it's great that you have such an enthusiastic and engaged cohort of people in quality improvement, and it's very promising for the future, I think.
Thank you so much, Dr. Walsh, Prashant, Vivek, all my participants and office bearers. Good night, stay safe, and see you again next month. Yeah, thank you so much.
Thank you, everyone.
Bye.
Good night.
Thank you.
Bye.
Good night.